Well, we have some excellent panelists on the session today. I will be giving them, each of them, a maximum of 6 minutes to say a little bit about themselves, their background, and some of their views on digital healthcare in the USA. But from left to right, we have Leon Eisen. Leon has been a panelist on one of my previous webinars. He's the CEO of a company called Oxytone, founded in Israel. They're wearable technology specialists, and they've got a lot of expertise in the use of digital technologies for remote care. David Levian is President and CEO of the Federation of Associated College of Health Trustees. He is the founder of that organization, and he's very kindly been at one of my previous webinars. He attends quite a few of them, and he put me in contact with one of the other panelists, Anthony Chang. Ron O'Donnell, I've known Ron for quite a while, although he hasn't been a panelist on a previous webinar. I've always had him in mind for joining us on a session. He's a clinical psychologist. He lives near Boston in the USA, and he works at Arizona State University, where he delivers some online courses. He's a specialist in behavioral health care, but he's also, like me, a practitioner in the use of wearable technologies for personal health management. And then last but not least, we have Anthony Chang. Anthony is the founder of Artificial Intelligence Med organization. So he's actually a pediatric cardiologist by profession, and his passion is the use of artificial intelligence in medicine. So we have some excellent panelists. Before I ask them to say something about themselves, I would just remind you that if you have any questions, and I do hope that you're going to be asking plenty of questions, please use the Q&A box to type in your questions. You're welcome to use the chat facility to have conversation between yourselves and with individual participants, but if you can restrict your questions to the Q&A facility, it just helps me to manage the situation a little bit better. So that's our panelists. Without further ado, I'm going now to ask Leon Eisen to do his presentation. So I'm going to load up Leon's presentation, and he will take you through this short presentation about himself, about Oxytone, and some of his views on the developments of digital technologies within healthcare and medicine. Okay, Leon, I've loaded your presentation. Can you see that on your screen? You're muted at the moment, Leon. Can you unmute yourself?
Yeah.
Okay, Leon.
Thank you.
You can see your presentation, so if you would like to make a start.
Yeah, I see. Yes, could be great. Hello, everybody. David, thank you for the invitation to join this incredible panel. I expect a lot of interesting things from this panel and to learn something more as well. My background is some kind of very simple. I was fortunate to make my PhD study in Weizmann Institute of Science and then postdoctoral research in quantum physics. So I spent some time in science in few areas that were really interesting to me. Then I got some back and started like engineer in some great medical device company and startup, where I ended up as a chief technology officer. I really fell in love with healthcare, and this is field where you could innovate and immediately see impact what you have on the people. And then right about this time, my father collapsed on the street, at the same day when he was discharged from the hospital. So I saw in first hand for him how hard we made it for people with severe chronic condition to stay healthier and to live healthier life. So I immediately founded Occitan Medical to address career crisis in severe chronic disease care. And it is not a secret that top 5% of chronic patients account for 50% of annual care spending. Even I would say a little bit easy, about 20% of high-risk chronic patients consume 80% of all money dedicated to healthcare. So it is urgently needs some solution that really could help us. And I don't see this solution because I see the healthcare even today and during COVID, it will continue in post-COVID. I see it somehow in pieces. We don't have something combined like patient experience together. So because we have very fragmented care, we have fragmented measurements. Even for artificial intelligence, if you don't have enough data, if you don't have information, you cannot apply artificial intelligence. We have to wait more data. How long? If we measure once a day, once a week, how long? For a week? For a month? For a year? We don't have information. And this has a huge impact on our care today. We have false alarm. Physicians are burdened with all these stuff happening around. We have very big, huge lack of patient engagement. And for example, last data about clinical trials for pharma revealed that it's impossible, almost impossible to engage patients to some clinical pilots. And most important, our healthcare is post-event and reactive. So we developed totally unique technology that enables artificial-based solution and therapeutic titration of high-risk patients. It's specifically dedicated for patients with severe chronic conditions. What we do, we use wearable medical devices. It's not Fitbit, it's a medical device, FDA cleared, CE mark. This is the world first FDA cleared pulse oximetry monitor, by the way. There is no something like this in the market. And we are world first in the market with this monitor that generates the data. So we use such devices. We use continuous patient physiological measurements, and we apply personalized analytics. And in real time, we can understand what happened to patients. We can titrate patient care plan, and we can help physicians to decide immediately. And most important, it enables also very unique notification that do not bother physician and nurses and all care team. So it's a full platform. It could be integrated separately like device, or could be integrated like a platform. And this is what we offer to RPM, remote patient monitoring company, to pharma, and by the way, to nursing homes. For example, after our device was deployed in one of the nursing homes, for example, in Jerusalem, no any death happened. That's amazing. So please, next slide. So what we measure today, we measure blood oxygen saturation at risk. You don't need fingertip sensor anymore. Very easy and very comfortable. Heart rate variability. This is specifically for behavioral change. Respiratory rate, skin temperature, activity, sleep data, and actually medical grade sleep apnea index. And soon we add blood pressure, dehydration, and cardiac output. We hope to have it by the end of this year. Please, the next. So where are we going to come with all new technology for specifically for continuous remote patient monitoring? We call it enhanced remote patient monitoring specifically for these high-risk patients. First of all, these patients are not engageable. They cannot actively participate in their care management. They should have passive measurements. I saw a lot of CHF or COPD patient grade 3-4. They are not manageable at all, and they are not engageable at all. So we have to put something on these patients and data should flow continuously. And we have to understand a couple of days before if any exacerbation happens. And if it happens, actually, we can keep this patient at home. Like today, we keep COVID-19 patient at home. If there is no very serious condition, and we can apply some care to this patient and monitor like an ACU based. So we can apply AI and we can understand, we build patient baseline, and finally we have everything about patient. We know this patient, like Amazon know what we want to buy. We know exactly what should happen with this patient in the next couple of days. So the goal is zeroing avoidable hospitalization and definitely cost. Please, next. So we have so far high impact. Just in January, we got to the market. And we have a lot of very good customers like Ascom. This is the biggest European telecommunication company, and Cigna, for example, and others. In London, we are connected to London Sleep Center, and it shows high impact. So very high patient compliance to wearable. You don't have to stop everything and to measure blood oxygen saturation, something like this. Everything goes smoothly and very high comfort. And all the beauty of technology, and we have 5 patents of this technology, that this is very unique. We call it flexible or elastic sensors technology. If you all get used to very rigid sensors like Apple that really press the wrist, our sensors embrace all the bone here, and very elastic, so they follow the shape of ulnar bone. It's very comfortable and very accurate data. That's why we have FDA clearance. So this is where we are. I think the future in enhanced continuous monitoring in wearable sensors and maybe laterly in implantable sensors. And what's important that COVID-19 just show that we're not ready to help high-risk patient or complex disease patients. And still, we are trying to take low-hanging fruits. This is difficult, I understand, but paradox that patients who consume 80% of our money do not have anything, any tools to help them. And this is what we're solving.
Thank you very much for that, Leon. I'm now going to move on to Ron O'Donnell and ask him to share some information about himself. So I'll just load up his presentation and ask him to take us through a little bit about himself, his background and his views on the future of digital technologies in the USA.
Thank you, David. I'm a clinical psychologist and clinical professor at Arizona State University, and I'm focusing on behavioral health technologies. I define behavioral health broadly to include certainly common behavioral conditions, depression, anxiety, alcohol abuse, but also health behaviors, nutrition, physical activity, taking medication as prescribed. These are all health behaviors. And one thing I want to cut to the chase with is, what's the impact of COVID-19 been on behavioral health via technology? The impact has been an explosion and a transition to in-person going to online psychotherapy. So because of COVID-19, clinicians, psychologists, social workers across the United States are now doing their psychotherapy sessions on Zoom. Now that's great. That's certainly a step in the right direction for health technologies. We're able to reduce barriers like patient travel to the office. There's convenience factor, decreased cost. There are also some negatives. Many patients and clinicians prefer the in-person visit. You lose some of the social cues you might gain. So that's a good thing in the right direction. But is that really innovation? You can stop there, David. I would say no, that replacing in-person 1-hour visits with online 1-hour visits, that's a great transition of technology, but that's not the end goal. I think my colleagues here and I recognize things like using smartphone apps to improve your health, using wearable technologies. Those are all things you want to try and focus on. Now, my program, Doctor of Behavioral Health, Arizona State University, we're training a new workforce of clinicians and managers with a big umbrella: behavioral health clinicians, social workers, counselors, on the medical side, physician's assistants, occupational therapists, to become expert doctoral clinicians, managers, working with the family doctor or GP to help address the patients who have medical and behavioral conditions that impair their health. Next slide, David. So using myself as an example, I try to do the right things. I'm a health psychologist, so I exercise, swim, run, bike, lift weights in my home. I have a loving wife, 2 grown children, a great social support network. I'm doing the right things to try and keep healthy as I age. Next. And health technology plays a key role in that. I use my smartwatch. I use my app to track my pace, my timing, my calories burned. I try and use to focus on certain goals. Right now I'm trying to improve, for example, my speed of swimming. So swim stroke is very important. So health technology is part of how I live my daily life. Next slide. I'm an outlier though, because unlike most Americans, I don't really need a clinician to prompt me to exercise, to use technology. I enjoy doing that. Most Americans don't have that mindset, don't exercise enough, don't use health technology in these ways. Now, last of all, as I'm aging, I'm in my 60s now, you can't hold back the hands of time, right? So I'm experiencing chronic illness. I've had sleep apnea for a couple of decades now. And this is my Bluetooth, you go back, David, that's my Bluetooth-enabled BiPAP machine. I developed hypertension over the past year. I'm working on changing that via lifestyle. That's my Bluetooth hypertension cuff right there. And of course, old-fashioned daily weighing myself is a key way to manage my weight. That's also Bluetooth-enabled scale there. So these are all technologies I use to represent where America's heading. With the aging of the population, we're having more hypertension, diabetes. We can prevent, better manage these conditions with behavior change, and health technologies are a great tool for that. Next. Now, the technology does not only include things we have individually, right? Next slide, David, yeah. Our environment is also part of our health. This is a great story in New York Times about a device called Purple Air. So essentially you can put outside your house and it measures air quality. This is an map of California where they're having raging forest fires right now. And this writer talked about watching his sensor on his house. He can see as the sensor changes from red to yellow to blue, showing better health. He'll try and monitor his own environment and go outside for exercise, other things when the air quality is good with this little sensor that's being used by consumers across the country. Next slide. We also know that social support is critical, and for people who are either infected with COVID or concerned about COVID, there are many different self-help groups online they can now go to for support, information. This one is called Survivor Court. Next slide. This next one is called Body Wear, I believe, and they focus on COVID-19 specific support groups. So finding ways to connect with other people socially is also a key part of health technology enabling us. Next slide. And I work very closely with a colleague at my university who's developed a smartphone app that's been actually validated, meaning it's been proven effective in the veterans population in the United States. Nothing spectacular about this app. It has usual things you would see from most technologies: 24-hour real-time monitoring of sedentary behavior, physical activity, sleep with stimulus control, nutrition using what's called My Plate rather than the old-fashioned entering your foods and calories. So these kind of tools are increasingly common. We know, though, unfortunately, that if you give a patient a smartphone app and say, please use this, after a few weeks, most stop using it. So a key requirement now, at least in this stage, is to have a clinician, health coach, working with the patient to help them use the app, overcome barriers to use over time, become proficient at using the app as part of the routine, to become proficient at self-management using the app over the long haul, 6 to 12 months. Next slide. And with my colleagues here, I think the end state is this picture here, which really shows Internet of Things. How can we use the internet to develop a comprehensive way of managing, giving patients a feedback loop about their health in all areas: medical, physical, behavioral, environment. And this slide simply shows the patient on the far left engaging with their family doctor and going to a specialized integrated practice unit where they're getting recommendations for exercise, for nutrition, for using smartphone apps specific to their needs, to have medication adherence be a key focus, to develop their social networks more carefully and more fully. and to have this information fed back to the patient via technology and using that to help the patient slowly over time improve all these areas of their health. And of course, we have analytics engines. We'll hear about our other speakers on AI and machine learning in healthcare. That's really critical also at the analytics end, trying to identify trends that help the patient identify further ways to change their behavior. So in summary, we've gotten great progress. We're seeing great results in research. The challenge is most of my peers, psychologists, social workers, counselors, even nurses, are not really endorsing the use of health technology sufficiently. It's an untapped opportunity. They're relying upon their training from graduate school maybe many years ago when these weren't as common, but we have to make these part and parcel of our daily work with patients to help them address not just nutrition, physical activity, but also depression, anxiety, using mindfulness apps, things like that. So the future is bright, but the challenges are significant. And I think our goal is to help disseminate this knowledge throughout the population of treaters and patients. Thank you.
Thank you very much for that, Ron. We'll now move on to Anthony Chang. And Anthony doesn't have a presentation, but he's going to tell us about his work and some of his thoughts on how digital healthcare is developing in the UK. Over to you, Anthony.
Thank you. Thank you for the invitation, David. I am a pediatric cardiologist, still practicing pediatric cardiologist, and I have a background in data science and artificial intelligence. And I founded an institute at my hospital called the Medical Intelligence and Innovation Institute, or MI3 for short. And it's an institute to focus on deployment and education of artificial intelligence in healthcare. I'm also the founder of a multimedia platform based in the UK, actually, called Artificial Intelligence in Medicine, or AIMed. And I'm also the privileged editor of a book, as well as the editor-in-chief of a journal called Intelligence-Based Medicine, which is, again, focused on the theory and practice of artificial intelligence in healthcare and medicine. And lastly, I am the co-founder of the new American Board of Artificial Intelligence in Medicine, or ABAIM, and it's designed to disseminate the principles and practice of artificial intelligence, and it will be executing a certification process for any interested party, from students to practitioners, and even hopefully patients and families. So I basically have been interacting with quite a few people in the digital health space, I think for the following reasons. I think one, I always say it took a pandemic to get some of these things done. And one of the things that we've been able to accomplish at our hospital is our use of telehealth increased 25-fold within a couple of weeks. Something that we had aimed to do in the next 5 years took only 2 weeks. So that tells me that this capability was dormant and it just needed to be invigorated. So I think telehealth has really accelerated the development of artificial intelligence in wearable technology. And I think it's a wonderful opportunity, but I think part of the issue is the US government has to figure out a way, along with third-party payers, how to adequately compensate practitioners of telehealth as well as technology with all its capabilities. So that's takeaway number one is yes, telehealth and digital medicine has had a resurgence, but I think we really need to figure out a way how to compensate practitioners. I think takeaway number two is I think wearable technology is relatively mature compared to the artificial intelligence that will need to be coupled with wearable technology. I have some patients on wearable technology, but I think it's vastly underleveraged because there's no really embedded artificial intelligence within those devices. So I think in the future, I think any wearable device that doesn't communicate and certainly doesn't have AI is going to be of limited utility for the practitioner. So I'm a cardiologist, and it doesn't help me to have a patient with a wearable technology unless it does two things. One, it communicates with a central data repository, and better yet, it filters itself to give me key information. So I think we're still at the early stages of using wearable technology with intelligence. And lastly, I remind myself and my colleagues that you can have a great device and a great project, but and just similar to any AI project, you can have a near perfect device or near perfect model in artificial intelligence and yet have little or zero patient impact. So it's almost like you have to really think about patient impact first and then design your wearable or artificial intelligence design after that, because I think I'm seeing too many AI projects and too many wearable devices with very little patient impact because of a number of reasons, including logistics and including just not being able to figure out just how to make impact. So I think I would encourage everyone to figure out how to make patient impact. There's the good news is that there are lots of chronic diseases that need this sort of technology, both digital medicine as well as AI. So the field is very rich with opportunities, but we still need to come down to making patient impact. So with that, thank you very much for your time.
Thank you very much for that, Anthony. And now we move on to Dave Levian. Dave, I made you a co-host, so I'm hoping that you will be able to share your presentation. So I'll put you on the screen. Here we go.
Okay, so I've been a surgical educator for 33 years. I've practiced surgery, taught residents and medical students, and been on the faculty at multiple medical schools, achieved the rank of clinical professor of surgery, been interested in critical care, and I was among the first class to ever be inducted into the College of Critical Care Medicine. For the last 13 years, I've been CEO, president, and board chair of the American College of Healthcare Trustees. The American College of Healthcare Trustees was founded as a C corporation in 2013 with the mission to improve governance, leadership, and decision-making in healthcare. And we do that by virtue of in-person conferences and remote learning. We've had several conferences at the Johns Hopkins Mount Washington Conference Center, at Georgetown University, in Philadelphia, because there are 5 medical schools in a 19-block area. We had a great conference at Pebble Beach along the California coast, and that's what's pictured here. And that was on healthcare innovation. And then we had one in Washington, D.C., which was our attempt to make a contribution to solving the opioid crisis. We're a membership and education company. We have about 80 members and a mailing list of 8,000. And our curriculum is intended to transcend silos and foster meta leadership. And included in our curriculum are the principles of governance, innovation and entrepreneurship, bioethics, compliance and health law, and business decision making, as well as human resources. And we also have a strong entrepreneurship arm. We have a project that I've been intensely interested in for many years now on point of service focused echocardiography and artificial intelligence. We have a project using wearables and lack of heart rate variability as a surrogate for distress, treating that with biofeedback. We have a company called Worldwide Mobility Solutions to make travel easier for people with neurodiversity issues. We have a hospital turnaround company that uses, among other things, the medical value index, which rates all the hospitals over 200 beds in the United States in terms of quality and cost. And then most recently, we've been asked to represent investors buying up to 20 ambulatory surgery centers. Let's see, why is this not advancing? I think when we look at innovation, the model of Wang and Christensen is so important in explaining why so many sophisticated technologies have not really disrupted the healthcare scene. And the reason that Christensen gives is that these technologies are always implemented in a sustaining manner. And that is that they're aimed at what he calls solution shops. And in a sense, I've spent my career in a solutions shop where you need the most sophisticated education, intuition, and get personalized attention. And that's great for the sickest people, but it's not financially sustainable because it doesn't improve access. It doesn't expand access to medical care. And what Christensen talks about is disruptive innovation. And the new innovations aren't necessarily as good as what exists, and they're not profitable for the major companies. And in a sense, that allows new entrants into the market. And it takes a lot for a large corporation to develop innovation, because, as Diamandis says, true innovation means threatening your existing product line and your past investments, and breakthrough products disrupt the current business line. Okay, So disruptive innovation is less profitable to the dominant incumbents. It's usually introduced by new entrants. And as the trajectory of improvement continues, it becomes appealing to the best customers, and the dominant incumbents lose their competitive advantage. And as a result, better products can be sold for higher profit to what they call the best customers. Really, they mean the customers with the ability to pay. And in general, many of these products include more bells and whistles than customers really need. And to answer David's last question that he posed to the panelists, the issue in America for digital health is, on one side, you have a free-for-all where there's no regulation. And on the other side, you have over-regulation, which makes it very difficult to introduce new products and services. And of course, this is very important to me, because in my 20 years as chairman of surgery, one of my responsibilities was credentialing surgeons to do procedures. And you don't want to limit creativity, and you want to allow your surgeons to do new and innovative things. But by the same token, you have the responsibility of protecting patients and making sure that surgeons are properly trained to do the procedures that they're asking to do. And I think the same trade-off exists in the regulatory environment in the United States. The issue will be finding the right balance between free-for-all and over-regulation. Okay.
Oh, thank you very much for that, David. I'll just stop your screen sharing. So thank you very much for that, David. We've had some questions in, and I'd probably like to bring that first question up that we had earlier on, because I think it's very relevant to what we've been talking about. This is a question from Loy Lobo, and what he says is, I'm seeing early signs, especially in the UK, that with greater availability of PPE, physicians are starting to abandon telehealth interventions and retreating to the old familiar model. What else needs to happen before digital technology becomes more embedded in health services? So I think I'm going to go to Anthony and ask Anthony his views on that question, because he's already working on a daily basis in that kind of environment.
Yes, I think first of all, I've been pleasantly surprised at how providers and patients and families have adapted and how comfortable they are in this setting. I wasn't thinking the trajectory was going to be this steep. Actually, some patients even have told me that they would actually prefer more than half of their future visits be in this format. Some of my patients have chronic heart failure. It's very, very inconvenient for them to go to the hospital unless they really need to. So point number one is I'm very surprised and very happy that this mode of delivering care that's been dormant, as I mentioned earlier, has really been activated. And I think for patients and providers, it will be a very valuable resource. And as I said at the outset, it has to be coupled with some reimbursement that's going to be at least not a disincentive to use this mode of care. It doesn't have to be very sort of equal to an in-person visit, but at least has to be removed as an obstacle to patients and providers delivering this care. And lastly, as I mentioned also, I think one way we can make this kind of visit more attractive is to really have a proliferation of appropriately designed and used wearable technology as a partner in telehealth. I think that's going to add a lot of value because, as it was alluded to earlier by at least one speaker, it's transitioning from episodic care to continual care, which I think providers and patients will find very attractive. So I think if those three things can be in place, I think the telehealth and digital medicine will be here in a much more robust form that we need it to have, given how many patients have chronic disease management and how complicated it is to deliver.
Thank you very much for that answer. I think you made some very interesting observations there. I think on the one hand, so if you look at the UK, on the one hand, what's happened with coronavirus is that as people become more used to tools like Zoom for their social interaction, Zoom, WhatsApp, etc., and other applications, then the leap towards telehealth and having online consultations is not that great. But against that, as you've identified, and also in one of the other questions that been asked, one of the challenges is that particularly with medical insurance, it's been a bit of an uphill battle to get medical insurers to recognize telehealth as something that clinicians ought to be paid for. But moving on to the area of the notion of wearables and continuous monitoring. I did an interview last week with a company that's been working with the use of virtual reality for rehabilitation. And one of the observations that they made, which I think Leon may well be able to comment on, is that one of the challenges for investors, and particularly people involved in the pharma industry, is that they are so used to validated clinical trials involving thousands and thousands of patients before a drug is validated. But when you're talking about drugs, you're talking about a product which is pretty stable, and it's a single, easily identified product that can be put onto the market with known impact on patients. But when you're talking about wearables and you're talking about medical technologies and software applications, the real challenge is that the hardware is changing every year. And not only is the hardware changing every year, you've got almost an infinity of different kinds of applications that you can run on the hardware. So it's very difficult to get that kind of validation. Leon, you've got experience of getting FDA approval for a wearable device. What's been the main challenges for you in getting through this kind of hurdle?
I think the main challenge is how people think, even in FDA, because it was a huge noise and confusion around wearables. If you take a look on some market research made by, I don't know, Frost Sullivan and others, very, very good companies, finally you will find market research which is called healthcare or medical devices, and you will find their Fitbit, Apple, and all these bullshit from medical device point of view. So it's a huge confusion, a lot of noise, and people cannot separate some wearables that is medical device, and they have, I will call it, they have ability to be wearable, and real wearables for wellness. It's a big difference. For example, take Aura, they measure sleep. Okay, good. Do they measure sleep apnea? No. Why they're accepted like a healthcare or device? I don't know why. It's a bullshit. Same with other devices. A lot of investigation of using Fitbit for COVID-19. Is it a wearable device? No. Could you rely on this data? No. Somebody checked this data? No. But it's, again, people try to use it. And then they have to decide, or physicians have to decide based on this data, how a physician could decide. How artificial intelligence could make something based on these data. So this is very important. First, we have to separate what is noise and what is real medical device. So you have to go to FDA, get this data, and get verification, validation, and say, okay, this is medical device. And again, this is an FDA. People just concerned about wearables because wearables was somehow equal to something that is wellness. So now we're talking, okay, this is medical device, like any other, like Massima, like Nonin. Nobody says this is wearable. This is medical devices, medical pulse oximeters, medical blood pressure monitor. And just second feature, it's wearable, happy to be wearable, so people could wear it.
I think you made some interesting points there, but there are many different components and dimensions to wearables and their impact on personal health management. I happen to be using a Fitbit at the moment, and previously I had a Jawbone Up, and by monitoring my daily activity and my diet, I was able to have quite a significant impact on my personal health, even though I accept that they are not medical devices. So I want to go now to Ron, because he's kind of shared some of those experiences. So when we're talking about how you get greater patient engagement, having accurate medical data from the medical profession is obviously critically important if you want to manage people's care. But what about influencing people's behavior? What do you see as the critical factors in helping people to change their lifestyle behaviors?
Well, the technology is a tool, and at least at this state of our progression, we haven't got technology able to really engage a patient, especially for those who are not motivated and what we might call resistant. So having a clinician able to help engage the patient, activate the patient, motivate the patient, to be aware of why these behavior changes are important. Why should you change nutrition? Why should you be more physically active? Why should you take medication as prescribed? And then showing how these technology tools can facilitate and achieve that goal, make it easier. That's the big, I think, next step, to make sure our clinicians are aware of how to educate patients, motivate patients, and then show them the way to use technology. And that leads to the patient learning, well, I can use this routinely without my clinician prompting me, checking in, and find benefit myself. That's really the self-management goal we're trying to find here. Can the patients use these tools routinely, whether they're healthy or have chronic illnesses, to better manage their health? And that's where we're headed in the field. But again, I think the biggest gap is clinicians being aware of the importance of this. Telehealth is great. We're going to see in behavioral health for psychotherapy, most insurers like to keep on paying for this well after COVID-19. But having individual one-to-one video therapy sessions is a far cry from using the great array of healthcare technology tools out there for patients to improve their health.
I go to David now because your presentation looked at some of the barriers to innovation and some of the characteristics of new innovative devices. So, what's your view on how you combine the validity of medical data that you get from clinical devices with the type of influences of personal behavior that Ron is talking about, and also provide benefits to the healthcare insurance people? Are we moving towards a situation where you're creating an ecosystem of technology providers? Just give you a simple example from another industry, and that is motor insurance. Within the motor insurance industry, with the development of devices which can be embedded in your car that monitor the state of your driving, they are able, through that, to be able to offer better premiums or better conditions to drivers. If you can demonstrate that you are driving well, you get the benefits. Are we going to see this with wearables and clinical devices and gamification, so that insurance companies are able to justify the investment in wearable technologies and these devices, knowing that they will get benefits from improvements in lifestyle behaviors? Are we going to see this connection in the future, do you think?
Well, yes, and I don't think that we should forget the priestly function that's involved with healing. I think we need to be both high tech and high touch, and that technologies like telehealth shouldn't replace the physician's visit. When President Eisenhower had his heart attack, there wasn't very much that his physicians could bring to bear. They gave him supplemental oxygen and morphine and rotating tourniquets, and it cost very little money to take care of him. But now, if you have a heart attack, an MI, you're going to have a percutaneous intervention. You're going to have medications that cost thousands of dollars. And in spite of the fact that medical care is more effective than it's ever been, the public has lost some of its reverence for the physician. And that can be problematic, because so much of the healing we do is due to the priestly function of the physician. So I don't think that telehealth should replace the physical visit. As Ron said, you lose a lot of cues that you might otherwise gain. But I think telehealth and other technologies, including wearables and continuous monitoring, are going to extend what we do and make it available to more patients and more convenient. But again, I don't think it should replace the in-person visit. Now, insurance companies are now paying for telehealth, and this virus scare has played a role in that, and even hospitals are getting waivers so that they don't have to comply with HIPAA regulations as stringently. So as Anthony said, it really has hacked telehealth. It's increased its proliferation many-fold, and I think that's a good thing. Now, David, you talked about stakeholders, and I think that's very important, because one of the things that impedes adoption of new technologies like the Internet of Things is finding a business model that pays for it. And gamification is a perfect example. I was approached several years ago by a chap that had developed an app to teach people when they should go to the emergency room and when they should not. And the business model that he wanted to adopt and he approached me about was this gamification would be sold to the insurance company, and they would use it to lower the family's premium if they played this game and learned when to go to the emergency room and when not. So this is a very similar model, David, to what you were mentioning with car insurance. If you put this app in your car that sends you a nasty gram if you go too fast or turn too abruptly, they lower your car insurance premium. Well, they'll lower your health insurance premium if you play this game that tells you how not to abuse the emergency room. So it's a similar phenomenon.
Yeah. Thank you very much for that. Yes, I agree with that, and you are seeing, not necessarily with health insurers, although you are seeing it in the UK, for example, with Vitality Life. They are offering special deals for individuals who take out their insurance. They get a special deal on an Apple iWatch. Now, although that is not the same type of devices really that Leon is talking about, fully medical grade device, but a lot of wearable devices are moving in that direction. And I think if we're able to use the power of collaborative technologies, we can create this ecosystem of win-win relationships. But I do think that we have to differentiate between the use of digital technologies for preventative healthcare and digital technologies for interventions when people do become ill. So I'd like the panelists view. I'll go through you individually to ask your views on where do you think the emphasis should be placed in the development of digital technologies? Should it be for preventative healthcare, or should it be tools that provide more responsive and more effective healthcare, whether that be telehealth, whether that be artificial intelligence used to automatically alert physicians when patients start to demonstrate problems with their vital signs? Where do you see the balance? So I'm going to start with you, Anthony, and then I'll go to each of the panelists and ask for their views. What's your opinion on this?
Well, I think we need to deliver a continuum of care and not sort of treat patient care as a dichotomy between chronic disease management and preventive care and then acute care. I think we're going to start really, and I think I'm comfortable managing my patients even when they have a flare-up of heart failure, because I think with more telehealth, I will know them better and see them more frequently. So rather than have these episodic care, and especially when they get sick, I think you're going to see a flattening of the continuum of care so that you see them more frequently, but the acuity should be less, at least given chronic heart failure and other chronic diseases as well. So I think we need to get away from the dichotomizing care as acute and chronic and just deliver good care any way we can. So in a way, our lives will be more difficult as clinicians because now you're counting on a more complex nature of care, but it's going to be better outcome for patients.
I think you make a very valid point there. The notion of telehealth and telemedicine allowing physicians to have more regular contact with their patients. And if you combine that with wearable technologies, that will be much more informed regular contact with their patients. And so you are delivering a better patient experience or a better citizen experience, shall I say, of healthcare. So, Leon, what's your focus on this?
I think, first of all, let me explain your last message. You are a relatively healthy guy. You are using wellness technology, and you have some bias because you pick up from what you measure only what works for you, what you need, and you do not pay attention to what doesn't. For a very sick patient, 80 years old, 90 years old, they don't have such bias. And they cannot afford picking up only what works for them. Everything from this device should work for them. And this is the main difference between your behavior and your attitude to wellness devices and to wearables devices and to medical devices. And I think the future is in, first of all, we have to generate information. And second, we have to apply this information. Generate, analyze, and apply. Wearable devices, medical, wellness, doesn't matter. It's for different use for users, but it doesn't matter. They generate information. Then you apply AI, you analyze information, you prediction, and then you apply this prediction to avoid exacerbation and to avoid the problem. I think it works this way.
Yeah, I accept your point. I am biased in the sense that I'm using a device which happens to work for me, and it happens just to influence my behavior. But as you say, I'm lucky enough to be relatively healthy, but I'm acting on that advice. But what I wouldn't like to see really is too much of a differentiation between wearable devices like Fitbit and other devices and devices like yours. I wouldn't like to see devices like oxytocin only being used for people with chronic conditions. I would like to see the accuracy of medical data being applied universally. So if you combine that with what Anthony was saying with regular telemedicine visits, use of AI to alert physicians when there's a problem, you're starting to get the best of both worlds. Ron, what's your take on this?
I think the answer to your question is clearly from a science perspective, prevention is where we should invest our work. We know that cardiometabolic risk factors begin to arise in childhood. And by people in their 30s, they're now progressing to chronic disease. So we should address that. But of course, our healthcare payers in the United States are focused on paying for acute care, not prevention, despite some minor tweaks to that over the last number of years. So prevention is key. And secondly, I think it's, as Anthony mentioned, the false dichotomy. As we age, we're all going to experience different health problems that are chronic, acute, and using technologies routinely. When we're healthy, when we're not, should be the norm in the future for all of us. I think it's a false dichotomy, but I certainly think prevention is underutilized in the American healthcare system.
Thanks for that, Ron. Dave is about to leave us. So, David, can I just ask you just for a closing remark before we do at the finish time now. So could you say just a few words before you go?
Yes, first of all, I wanted to thank you, David, for organizing this. And I'm really honored to participate with the other panelists who did a great job. A lot of untoward events occur at transitions of care along the continuum of care. So even the process of being transported from the intensive care unit to the operating room is hazardous. A lot of bad things can happen in the elevator because the IV bag is put on the patient's chest and they don't get the inotropes they need, or they were on 10 centimeters of PEEP and they don't use a PEEP ambu bag to ventilate the patient in the elevator. Similarly, untoward events occur when a patient is transferred from one level of care to another, like hospital to nursing home, or nursing home to home with home monitoring. So I think we can use data mining and other digital technologies and remote patient monitoring to obviate some of these hazards and improve patient safety. So it's a brave new world. It's exciting. And David, I thank you for organizing this. And I'm sorry I have to leave on exactly on the hour, but thank you again very much. I appreciate it.
Yeah. So thank you very much, Dave. I'm now going to draw the session to a close just by saying thank you very much to our participants for your questions. We tried to answer them all. If you've got any other further questions, please don't hesitate to get in touch with me directly. So it only remains me to say thanks to all our panelists, and just a reminder, as you're leaving this event, you should have a survey feedback form come up. I'd be grateful if you could take a few moments just to complete that, to give some feedback on this event and what you would like to see for future events.